Okay, so good afternoon, everyone. For today, we're going to take up the female genital tract. And I'd like to use this illustration to give you a background of the embryology and anatomy of the female genital tract. The germ cells arises from the yolk sac at around fourth week of gestation. Then around 5 to 6 weeks, they are supposed to migrate into what you call as the urogenital ridge. One important structure that you must remember is the lateral Mullerian duct, which is in this illustration, is this one. So the Mullerian duct at around 6th week of development, through invagination and fusion of the coelomic lining epithelium is formed. This tends to grow caudally, and the caudal growth brings it to fuse in contact with what we call as the urogenital sinus. The unfused upper portion of this Mullerian duct is supposed to be the one that will mature into what we call as fallopian tubes, while the fused lower portion will be the one that will develop into uterus, cervix, and the vagina. Now, the urogenital sinus will develop when the cloaca is subdividing by the urorectal septum, and it eventually will form the vagina and the vestibule of the external genitalia. The mesonephric duct is supposed to regress. If it persists, then that is what we call as, sometimes it may appear as cystic, and that is what we call as Gardner duct cyst. Now, this is a schematic illustration of the transformations. This one tells us that the lining epithelium, the yellow one, should be squamous. Basically, that covers the vagina and that of the ectocervix. In this region, you have the columnar mucin-secreting epithelium or glandular. The area where they meet is what you call as the transformation zone or the squamocolumnar junction. The transformation zone or the squamocolumnar junction is very important because it is where infection commonly arises and even gastric process. Now, let's talk about infection. The first on the list is what we call as herpes simplex viral infection. Herpes simplex comes in two forms. One, HSV1 and HSV2. HSV1 typically results in oropharyngeal infection, whereas HSV2 usually involves the genital mucosa and the skin. This is what I'm discussing this afternoon. Usually, 3 to 7 days after transmission, you will see ulcers or basically vesicular lesions like this in the external genitalia of your patient, often accompanied by other symptoms like fever, malaise, and tender inguinal nodes. Eventually, the transmission rate is very high at this point. This is what you call as active infection. These lesions are expected to heal spontaneously in 1 to 3 weeks. However, the problem with herpes is that it can migrate to the regional lumbosacral nerve ganglia and establish what you call as the latent infection. How do you diagnose the disease? If you perform a biopsy, the characteristic appearance would be the presence of multinucleated giant cells. The description is termed as ground, meaning the cytoplasm is appearing empty like this. Now, this is an example of an inclusion again, viral inclusion, indicative of herpes simplex virus. So, to diagnose the disease, you take a sample from the vesicular lesion. But you must remember that the transmission may take place during the active phase when it's in vesicle, but occasionally it may also occur during the latent phase. When I say latent or latent, this is when they are actually at the level of the lumbosacral nerve ganglia. The latent infection is in the lumbosacral nerve ganglia. The phase that is when we are talking about this is the latent phase. It can result to subclinical viral shedding. use of contraceptives can lessen the transmission. However, if the mother is infected and pregnant, passage through the infected birth canal may eventually transmit the disease to the neonates during birth. The second on the list is molluscum contagiosum. Molluscum is caused by a virus. Often the disease is or the variant of MCV has 4 types. It is usually appearing as a nodule, again, a papule with dimpled center. The diameter often ranges from 1 to 5 millimeters. If you do a biopsy, the arrowhead is pointing to cytoplasmic viral inclusions. It's actually the dimpled center that you see grossly when you examine your patient. Another infection that is quite common is fungal, particularly Candida albicans. The disturbance in the vaginal microbial system may lead to compromised neutrophil function, or particularly your T helper 17 T cell function. When this happens, you will know that your patient is having candidiasis because the common complaint would be vulvovaginal pruritus, erythema, swelling, and the characteristic curd-like vaginal discharge. So you have to demonstrate the presence of the fungal elements, which in this case are the pink structures that you see. They are usually appearing as hyphal elements. When this is established, then a diagnosis of candidiasis can be made. The next infection is a protozoa. These are examples of protozoa, which is basically your Trichomonas vaginalis. They appear usually or develop within 4 days to 4 weeks after sexual contact. The characteristic appearance of the cervix is described as strawberry. Along with vaginal discharge, vulvovaginal discomfort, painful urination, and painful intercourse usually follows. Do not forget that the classic description of the cervix for this patient is strawberry because it gives you a fiery red appearance. Now, sometimes bacterial vaginosis is encountered, and the clue that more likely your patient is having bacterial vaginosis is that they will give a thin green malodorus described by the patient often as a fishy vaginal discharge. When this happens, think of Gardnerella vaginalis. Gardnerella vaginalis are basically cocobacilli, and one of the things that you can see on Papa Nicolau smear, as what I am showing you right now, is they tend to be in the cytoplasm of the cells. This is actually what you call as clue cells. The clue cells are indicative of bacterial vaginosis. So when we are interpreting PAPs, if we see a shift in flora, this is called a shift in flora because normally what you will see is bacilli as on the background. But as you can see here, what you can appreciate are cocobacilli. So the shift in flora and the presence of clue cells are then diagnostic of bacterial vaginosis, often due to Gardnerella vaginalis. There are other organisms enumerated in the book, which is not quite common, but may cause infection as well, like ureaplasma, mycoplasma, chlamydia, and treponema. Let us go to pelvic inflammatory diseases. Points of emphasis. 1, the most common cause of PID, gonococcus or Neisseria gonorrhea, is best demonstrated using a gram stain. You have to do a gram stain in which the organism is appearing as intracellular or extracellular gram-negative diplococci. Being a bacteria, it can also be cultured. It can also be that you can employ PCR testing to detect for its presence. Aside from Neisseria gonorrhea, there are also non-gonococcal causes of PID. When you say pelvic inflammatory disease, it is often always presenting as an ascending infection. It begins in the vulva, or the vagina and then spread upwards, presenting as pelvic pain and nasal tenderness, fever, and vaginal discharge. Eventually, it lodged into your fallopian tubes and ovaries, so that what happens or what is expected will be your salpingo-oophoritis, often with abscess. Since the ovaries and the fallopian tubes are involved, one of the common remote sequelae will be the fibrosis that develops may lead to infertility. And so one of the things that your patient may have eventually due to the fibrosis secondary to the healing of this infectious process would be fertility problems. Now, since it is in the blood, it can spread to other organs, as you can see, the endocarditis, meningitis, and even suppurative arthritis may be the manifestation of your patient. In the latter part of the book, there is another portion of PID, and I'm going to discuss that a little later. So let's go to the vulva. Next on the list is Bartholin cyst. Bartholin's comes from the infection is your position is perceived by your sense like in the form of an abscess. The diameter of the mass is often in the form of 3 to 5 millimeters. Is what will trigger the patient. Is termed leukoplakia. Leukoplakia simply means whitening appearance or plaque-like appearance. When you have this entity, you think of two more likely causes. One of which is what you call as lichen sclerosus. Lichen sclerosus, and the other one is what you call as squamous cell hyperplasia. So again, with leukoplakia, you have two things to remember. One, is it lichen sclerosus? Two, is it squamous cell hyperplasia? So to differentiate the two, a biopsy is performed. You take sections from the whitish area, and it is very easily distinguishable. Why? You start with the epidermis. In lichen sclerosus, the characteristic feature would be marked thinning of the epidermis. On the other hand, with squamous cell hyperplasia from the term itself, you will expect that the epithelium is this time thickened. In lichen sclerosus, there is usually degeneration of the basal layer. On the other hand, in squamous cell hyperplasia, usually there is increased mitotic activity in the basal layer. Both of the diseases will give you hyperkeratosis. That is one common feature for both disease. Now, another distinguishing feature is that the term is sclerosus because the sclerotic change is very much evident in the dermis for this entity. On the other hand, for squamous cell hyperplasia, this is not much evident. And the leukocyte infiltration, which can also be observed in lichen sclerosus, is another common thing in these two disease entities. Okay, let us try to talk about squamous cell exophytic lesions. When you talk of exophytic lesions, these are some of the terms that you. One is fibroepithelial polyp, otherwise known as squamous papilloma. Why is it called as such? It's called fibroepithelial polyp or squamous papilloma because, as you can see from here, you have finger-like projections or papillary-like projections that protrude as such. That's why the term is papilloma. On the other hand, it may be appearing as an ovoid structure lined by squamous epithelium on three sides, either which the lesion is benign. It is often with a fibrovascular core, as you can see from the image here, and even here. So fibrovascular core. Both lesions I'm trying to describe right now are benign, so that when you excise the lesion, it offers a cure to your patient. One particular importance that was described in your book is myeloma acuminata. Condyloma acuminata is very important because it is related to HPV, particularly 6 and 11 being variant. Now, when your patient is infected with condyloma or with HPV giving rise to condyloma acuminata, it is somewhat like the two pictures I've shown you. Take note of the distinguishing term, coilocytic atypia. For condyloma acuminata, coilocytes are expected to be observed. When this is present, this feature is diagnostic that more likely the cause of the disease is HPV. Again, for benign like condyloma, it is 6 and 11. Now, when you are studying the vulva, you are also having what you call as intraepithelial neoplasia. Let me use this. When you say intraepithelial neoplasia, the atypia is basically confined within the squamous epithelium. So like in this case, okay, this is what you call as vulvar intraepithelial neoplasia because the atypia is confined in the full thickness of your epithelium. Now, it is important to test for HPV. HPV positivity is often appreciated in differentiate VIN. Usually they are HPV negative, and usually they would appear as maturation of the superficial layers, hyperkeratosis, and basal atypia. So this is HPV positive, HPV negative. Now, that being said, why are we concerned with VIN? VIN is otherwise known as carcinoma in situ or Bowen's disease. A while ago, I was telling you that 6 and 11 is common for condyloma acuminata. When we're talking of malignancy, take note that the most common is HPV 16. HPV 16 is the most common. 18 and 31 are other variants that are also implicated. Usually, it will give you two patterns. One is what you call as the basaloid pattern, and the other one is what you call as the warty pattern. Now, these images are showing you, again, examples of the two tumor. So this is an example of basaloid vulvar carcinoma appearing as basophilic, and this is an example of a warty vulvar carcinoma, both of which detected B. When you are trying to take into consideration the differentiation for squamous cell carcinoma, if you see keratin pearl formation, they are regarded as well differentiated. If you do not see, okay, keratin formation, then more likely solid sheets is what you will appreciate. They are basically poorly differentiated to tumor. So these examples I'm showing you right now is an example of well-differentiated keratinizing squamous cell carcinoma, which is HPV negative. And this is an example of verrucous carcinoma of the vulva, which is also HPV negative. Now, take note that the word verrucous is emanating from the description in which the squamous epithelium appear a bit bulbous, as you can see here. Now, when we go to glandular neoplastic lesion, first on the list is papillary hydranoma. Papillary hydranoma is usually appearing as a nodule, commonly seen in the labia majora or in the interlabial folds. The term speaks for itself. You are to see papillary fronts, papillary projections, which are lined by two cell layers, an upper layer of columnar and a basal layer of myoepithelial cells. Now, there is a disease called Paget's, which is often more commonly encountered in the breast, but it may also occur in the vagina, or particularly in the labia majora. They will usually appear as pruritic, red, crusted, sharply demarcated areas. The problem with Paget's is that take note that it is an intraepithelial proliferation of malignant tumor cells. They also appear as halo. I have an image later that I'm going to show you surrounding the epithelial cells. And this is again denoting an intraepithelial proliferation of malignant cells. We have what you call also as malignant melanoma. Malignant melanoma often appears as a brownish black pigmented area such as this. And when you look at histologically, you will see the pigments and you will also see the infiltrative melanocytes. So these are examples of tumors that needs to be resected. Wide resection is very important in malignant melanoma. This is actually what you call as the dermal-epidermal junction. And as you can see, the growth of the tumor epithelial or the this side and not basically in the underlying dermis. So this is an example of an inside lesion. Okay, let's go to the vagina. When you're talking of the vagina, there are a lot of developmental anomalies enumerated in the book, but particularly focusing on the following. One is a septate or double vagina, usually secondary to DES exposure, abnormal proliferation of the glands, meaning they are normally present as red granular areas, and usually they consist of columnar mucinous epithelium indistinguishable from endocervical epithelium. And that is what we call as adenosis. I have already mentioned a while ago Gardner-Doxis, which is a remnant that should have been involuted. Now, let's talk about vaginal tumors. I'm going to use pictures, so I'm going to use this. In the vulva, I was telling you a while ago that there's such a thing as VIN or vulvar intraepithelial neoplasia. It goes the same for the vagina. The difference is, of course, the site. So for vulva, it's VIN. For vagina, it's VAIN. Now, the 1, 2, and 3 serves to tell you where to look for atypia. That is how I remember it, and hopefully it also works for you. If it is occupying the lower 1/3 with coilocytosis, this is more likely VIN1, and this is more likely HPV related. Why? Because you see coilocytes. If it is occupying the atypia, 2/3 of the epithelium, that's VAIN2. If it is full thickness, then this is an example of VAIN3. So is always graded, whether it is 1, 2, 3, if it occurs in the vulva, in the vagina, and later you will see if it's also occurring in the cervix. This is basically Pagets disease. As I have mentioned, Pagets disease is a malignant intraepithelial neoplasm. It is characteristically presenting with cells that will give you halo also. So just, well, somewhat reminiscent of coilocytes, but Pagets are usually confined along the basal layer. As you can see here, it is seen along the basal layer of the epidermis. Now, this is an example again of squamous cell carcinoma of the vulva. Again, you have malignant sheets of squamous cells that are infiltrating and keratin pearl formation. It can also be adeno. One of the most common is your clear cell variant. As you can see here, the glandular formation is very much evident. The only difference this time, the variant is called clear cell because, again, look at the cytoplasm, it appears as empty looking. Now, if we're talking of children, if your patient is a child, do not forget that it might be this disease. This is what we call sarcoma botryoides or embryonal rhabdomyosarcoma. It is classically protruding as a mass, as you can see here, grape-like structures common among children that are younger than 5 years of age. This is the classic lesion. Things to remember. Number 1, characteristically, the tumor cells will have a cytoplasm that is pushed to one side. That is what you call a round appearance. Sometimes you may appreciate the presence of striations. Number three, the tumor cells tends to be concentrated like a band underneath the epithelium. And this is what you call as the cambium layer. They are in the subepithelial layer. So these three things plus the grape-like structures, more likely the diagnosis is sarcoma botryoides. Let's now go to the cervix. OB would more like a speculum exam. However, for us, when it is resected, we can actually tell whether the cervix is nulliparous or whether the cervix is a parous cervix. So when we examine it, we actually look for erosions, ulcerations that may be present. This is an example of a specimen wide open, and this is the side of your endocervix. This is the side of your uterine cavity. That is basically your squamocolumnar junction. If we're going to look at the image under the microscope, this is what I am trying to show. So you have there the mature squamous cells, and I was describing a while ago the squamocolumnar junction here, and then eventually you have your columnar side. So why is this important? Some points to remember. For the cervix, the pH is normally below 4.5. If it becomes alkaline, what are the possible predisposing condition? Bleeding, sexual intercourse, reduction of lactobacilli by hydrogen peroxide decreases. These are some of the things enumerated in your book. When this is present, then it gives rise to cervicitis. Cervicitis do have a lot of etiology, and it can be bacterial, like for example, gonococci, cocci, chlamydia, mycoplasma, and even HSV. When you look at it under the microscope, you will see inflammatory infiltrates. Now, let us talk about it a little more further. This is an example of a normal squamous epithelium, and so is this. Why am I showing you all this? Because when you look at the cervix of a patient infected with any of this organism, you are to expect that inflammatory injuries are present in the stroma. It may be in the form of neutrophils, lymphocytes, or macrophages. So to identify the organism, you may have to do a culture and sensitivity, or you may look for viral cytopathic effects like what I have mentioned for herpes simplex. Usually that's in the form of inclusions or multinucleated giant cells. Now, let's talk about polyps. In any area, the polyp is supposed to be a protrusion coming from the mucosa, which is attached by what you call as a fibrovascular stalk. So this is the stalk, and that is your polyp. The normal lining epithelium of your polyp emanates from wherever it is attached. So like here, it is columnar mucin secreting epithelium. It is exhibiting a fibrovascular stroma. When it is occurring in the endometrium, it does the same. You will know that it is endocervix or endometrium based on the lining epithelium. Now, if you're going to look at the polyp, there are areas which may have a little more glands than usual, and this is what you call as microglandular hyperplasia. From the term itself, it's increased number of glands. The lesion is benign, but it is often associated with endocervical polyp and sometimes with exposure to hormonal therapy. You may also see some endocervical tunnel clusters, which are actually dilated structures filled with mucinous material. When one goes into menopause, one of the changes that you will observe will be atrophy. So a while ago, I was showing you the normal epithelium. Let me go back to that, in which it's supposed to be that there is, as it matures, you actually lose the nuclei. It tends to be flattened. On the other hand, in an atrophic cervix, the maturation, okay, the empty nuclei here is lost, and you will actually see full thickness with nucleus. However, mind that you should not see atypia. Why am I emphasizing that? Because a little later, I'm going to talk about cervical intraepithelial neoplasia. So let's talk about cervical tumors. Often, as I have said, it's caused by HPV, particularly 16, HPV 16 majority of the cases. Now, the ability of HPV to act as a carcinogen, eventually developing into carcinoma, it depends on viral proteins E6 and E7. Okay, E6 and E7. HPV can infect mature squamous cells. Viral replication occurs in maturing squamous cells. The viral E7 protein binds to the hypophosphorylated active form of your RB or RB gene and promotes its degradation via the proteasome pathway and binds to inhibits P21 and P27. So the problem is then you have enhancement of cell cycle progression, and it impairs the ability of the cells to repair damaged DNA. So you have a dysregulated growth, and eventually you may end up with a mass that is easily appreciated. So this is the benign one. Now, let us go to the possible risks that may eventually lead to dysplasia. So the spectrum is benign and then dysplasia. When you're talking of dysplasia in the cervix, you have to remember that there is a three-tier classification, 1, 2, 3. So just like in the vagina, if you are following my discussion, this lower 1/3, 2/3 full thickness, okay, mild, moderate, and severe. Now, in the book, they actually divided also it into, which is the current classification, into a two-tier pattern. One is what you call as the low-grade squamous intraepithelial lesion and the high-grade squamous intraepithelial lesion. So take note, 1, 2, 3, mild, moderate, severe, but L-seal is basically 1, 2 under H-seal. Now, this is an illustration of your HPV infection. As I was telling you a while ago, HPV infects your immature basal cells of the squamous epithelium in areas of epithelial breaks or immature metaplastic squamous cells, which is present in squamocolumnar junction. HPV cannot infect the mature covers the ectodermis, vagina, or vulva. Take note that the word damage is important to the surface epithelium, which allows the virus to access the immature cells in the basal layer. So you are infected with HPV, one thing that you can do to screen is the Papa-Nicolau smear. And again, coilocytes, which I am pointing right now, is very much evident. Now, if you do biopsy, this is what you will see. You will see coilocytes and you will see atypia in the lower 1/3. So if you're following, that's CIN1, mild dysplasia with coilocytosis. And the perinuclear halo that you see here is an example of coilocytosis, this time involving PAPs. So let's talk about this slide. So this is the normal superficial cell. That's a normal intermediate cell. Superficial and intermediate cell are almost of the same size and shape. The difference is the color of the nuclei, superficial cell being eosinophilic, intermediate cell being basophilic. The nuclei is often described as pycnotic. That's normal. When you have L or CIN1, mild dysplasia, take note that this superficial cell now is like this. So one of the remarkable change would be the change in the size of the nucleus. Number 2, the irregularity in the nuclear contour. Number 3, the prominence of the nucleoli, and somewhat the chromatin pattern is very much appreciated. Take note that this has seemingly an empty or a halo that surrounds the nucleus, so that tells you that more likely this is HPV related. As it goes up, 2 and 3, this is H-seal. It's very easy to recognize. Why? Because the nuclei is basically what you will watch out for. As the nucleus increases, the cytoplasm decreases. So that in CIN3H cell, that is the cell with lesser amount of cytoplasm and a bigger amount of nuclei occupying the diameter of the cell. Now, that's PAPS. Let's talk about biopsy. So this is normal. That's CIN 1, 2, 3. Y again, 1/3, 2/3 full thickness. Okay. So these are termed as dysplasia. Why? Because there is disordered growth. Diba? Normally, you should see, as you can see here, a nucleate. Here, you still have nucleus again. So nucleation is gone. You have full thickness atypia. And when this is present, then that tells you that your patient is having mild, moderate, severe dysplasia. L-seal, H-seal. Okay. Now, let's talk about L-seal. L-seal is low-grade squamous intraepithelial lesion. So these are coilocytes. That's the lower 1/3 coilocytes, and these are coilocytes again on Papa Nicolau smear. You can do actually a spectrum of workup. This is what you see on H&E. You can do special stains, like for example here, this is in situ hybridization aimed at the presence of the human papilloma virus. So the black thing that you see here is an example of the presence indicating that the virus is present in the epithelium. They tend to divide. That's why the change is of the epithelium. And Ki67 is an example of a proliferation index or a cell cycle index, cell division index marker. This one is P16, okay, which is basically characteristically there is upregulation, and this is commonly associated with HPV infection. So let's take a look again at this slide. So if you're following, this is normal, squamous. This is dysplastic. Again, that's normal, intermediate, that's dysplastic. So when we are interpreting the PAPS, we are very much looking for these changes in the nucleus and in the cytoplasm. Types, one is moderate, the other one is severe. Again, moderate is 2/3, severe is full thickness atypia. As you can see here, this corresponds to mitosis. Those are actually mitotic figures. Again, what's the marker? If you were able to get my discussion, that's Ki67. Sometimes the atypia may be so marked that it can actually be labeled as Ki3. This is an example of H-seal extending in the cervical. This is the endocervical. So again, the change is squamous. That being said, the most common type of cervical carcinoma is squamous. This table will show you its progression, regression, or persistence, so that when you are diagnosed with either L-seal or H-seal, close follow-up is really recommended. Now let's talk about these sample specimens. The next few slides are examples of malignancy of the cervix. As you can see here, that's the mass. In here, that's the mass. In here, it is basically more bigger, and it somewhat extends almost near the lower uterine segment. Here, this is somewhat more extensive. Why? Because you needed to resect the adjacent intestinal segment because of the adherence of the mass here. Okay, so you also need to resect that portion of the intestine. On the other hand, this goes the same when you open it up. The mass now extends to the uterine fundus, as you can see. And again, adhesions in the adjacent structure warranted the resection of this adjacent intestinal segment. So what am I trying to say? When you are diagnosing malignancy, later you will see the slides of staging. Staging is very important because it tells the extent of involvement. Among malignancy, the best is MICA. What is MICA? MICA means microinvasive squamous cell carcinoma, meaning you only have a small nest of cells that went beyond the basement membrane and is now in the underlying stroma. On the other hand, you wouldn't want this because these are sheets of squamous cells exhibiting keratinization, and they are now invading the stroma. So MICA, when you diagnose MICA, you have to know the extent of invasion going down and the extent of invasion going sideways. So this has to be measured, and usually the cutoff is that it should not exceed 5 millimeter or 7 millimeter in horizontal extent. If it does, then you change the classification from microinvasive to invasive. So this is an example of invasive. Invasive usually presents as solid sheets and tongues that are invading the desmoplastic stroma with or without evidence of keratinization. Again, these are evidence of keratinization. So this is an example of, well, DIF. If you do not see keratinization, but merely solid sheets, then as I have said a while ago, that's an example of DIF. If you see glands and solid, then that's an example of moderate differentiation. Some cells would appear as round blue cells like this, and this is what you call a small cell carcinoma. Cell carcinoma, be it served any other organ for that matter, the characteristic cellular molding is almost always appreciated. Like in the ago, when you say characteristic appearance, as I have already mentioned, would be the broad bulbous pushing border that invades the underlying dermis. When you say glands, again, the term is adeno. So look at these two glands. This is normal, basal nuclei, mucin secretion on top. Look at how atypical the cells become on this side, but you do not see any evidence of stromal invasion. So this is an example of in situ. Next slide is a better representation. This is the gland. This side is the malignancy. It is confined within the gland. That's why you say it is as in situ. When you see that the glands are now haphazardly arranged in filtrative manner, often the reaction of the stroma is desmoplastic or otherwise known as fibrous, then that you label as invasive. So I hope you're following microinvasive, invasive. Okay. Now, there are different variants. One, it can be mucinous type, obviously, because you have mucin secretion in the lumen. Two, it can have viloglandular formation like this, papillary-like structures. It may resemble that of the endometrium. So that's the endometrioid variant. Or it may be giving you clear cell cytoplasm. That's the clear cell carcinoma. So these are the different variants of carcinoma of the cervix. Sometimes you may see two patterns in the same tumor. Like here, you have glands on this side, squamous side. So that's an example of adenosquamous carcinoma. There are also cases in which you may appreciate cribriform pattern with eosinophilic material reminiscent of the ones seen in the salivary gland. And this is actually what you call as adenoid cystic. So I have shown you the types, I have shown you the gross. Why? Because these things matter when you do the staging. The staging is very important for prognostication purposes. The 5-year survival rate is very important for you to know what to tell your patient. I hope at this point you have realized the importance is pap smear. Ideally, your population is around 20s. You have pap smear within 3 years of onset of sexual activity and then every 3 years thereafter. If you go beyond 30, the frequency is this. So this is a very good way to screen and eventually prevent lesions. I have already mentioned this. We have now vaccination for these variants. This is more common in the benign, 6 and 11, and this is more common in the malignant side, 16 and 18. Okay, let us now go to the uterus. The uterus, I want to use pictures to explain. So let us go here. When you are an OB-GYN, you will look at the specimen exam, but when you're a pathologist, you are looking at the DNC specimen of patients submitted to you by OB-GYN. And so you have to look for changes to know what is the phase of the patient. If you see tubular glands like this, I'd like to use the next picture. Okay. Tubular glands like that, that is indicative of proliferative phase. The glands are straight, they are tubular structures, they are lined by pseudostratified columnar epithelium. And usually mitotic figures, which are the darker staining structures that you see, are in abundance. The stroma is expected to be cellular. Then ovulation happens, endometrial proliferation ceases, and basically you have ovulations initially marked by the appearance of the secretory vacuoles. First, the secretory vacuoles are expected to be beneath the nuclei. So that is your nucleus right on top near the lumen, and that is your secretory vacuoles underneath. Now, this is what we call as subnuclear vacuolation. When this is present, this is telling you that this is secretory phase, and eventually the basal vacuoles then move into the apical surface, okay, as you can see here. So it is now on the luminal side. When secretion is maximal, like in this case, it is more likely in the 18 to 24 days, and the glands are basically dilated. So somewhat by the fourth week, they would appear as having tortuous or serrated appearance, which is characteristically termed as sawtooth appearance because of the secretory activity, shrinkage of the glands, and the irregular contour that you can see here in the lumen. Now, what is happening in the ovary? Let's talk a little about that. The ovary is supposed to have progesterone when you are in the secretory phase, but when corpus luteum dissolutes, the progesterone level goes down. And so eventually the corpus luteum dissolutes. And so the functionalis layer degenerates, and it now leads to bleeding. That happens, you will see evidence of menstrual endometrium. This time, the glands tends to be more fragmented. In menstrual endometrium, stromal bond is characteristic. Now, in some patients, there may be hypersecretory activity, and this is what you call as Arias-Stella reaction. It is commonly seen among pregnant women. When you see this and the patient is not sure whether she's pregnant or not, it is best to do a pregnancy test, because features of Arias-Stella reaction connotes that there is pregnancy. The second change that you will see is, look at this. The stroma of the patient is expected to be decidualized. Now, let us go to DUB. An OB-GYN usually submits a specimen to us because of DUB, dysfunctional uterine bleeding. Usually, abnormal uterine bleeding can be caused by a well-defined pathology condition, like for example, enteritis, polyps, or myomas, neoplasm, or hormonal imbalance. It produces dysfunctional uterine bleeding. Medical term, lack of normality or an underlying organic or structural cause. Now, I have already discussed with you the normal cycle. There are cases in inadequate hormonal imbalance brought about by either endocrine problem or ovarian lesions or metabolic problems. It can give rise to abnormalities and leads to AUB. Now, let us talk about AUB. In the image is what you call as stromal breakdown. The most common cause of dysfunctional uterine bleeding is anovulatory endometrium with stromal breakdown. When you say stromal breakdown, the glands are often in the proliferative phase. It may also be that there is chronic endometritis. But I want to discuss more the stromal breakdown. It is one cause of anovulation. This is what you call as stromal balls. When the glands collapse, in the stroma, you will appreciate the presence of aggregates of brown blue cells, which basically corresponds to the stromal cells. And these are the disrupted crowded glands, often in the proliferative phase. When you see this is an example of stromal breakdown, which may indicate that your patient is having anovulation, which is the cause of the bleeding. Another one is the so-called disordered proliferative endometrium. I have already explained a while ago that proliferative endometrium is classically tubular glands. When you see the term disordered, that should remind you that what you will appreciate are cystically dilated structures as well. It may then be reminiscent of what we took up in the lab, which is simple hyperplasia, but do not mistake that for that. Why? Because in here, the glands somewhat are not so near each other. There is basically intervening stroma. That's the difference. If it is hyperplastic, usually there is little or no intervening stroma. The glands may be cystically dilated in both, but it is only few if it is disordered proliferative. The cause of the bleeding may be endometritis, divided into two, acute and chronic. Now, for chronic, take note that it is a must to see plasma cells. These are examples of plasma cells. They are cells which will give you a nuclei that is pushed to one side, characteristically termed as eccentric. When you have this, then that is indicative of chronic endometritis as the cause of bleeding. These are examples of bacterial colonomyces, which may eventually again lead to bleeding problems. Now, let's talk about endometriosis. Endometriosis is you are menstruating in other places outside of the uterus. Again, when you menstruate, you also bleed in these areas. Why? Because there are endometrial glands and stroma also in these areas. There are 4 theories. One is regurgitation. They say that endometrial tissue implants at ectopic sites via retrograde flow of menstrual endometrium or retrograde menstruation through the fallopian tube. That is why you also bleed in these sites. The other one is metastasis theory, which says that endometrial tissue from the uterus can spread to distant site. That's why the term is metastasis, like these sites. The third is metaplastic, which means that endometrium arises directly from coelomic epithelium, from which the Mullerian duct and ultimately the endometrium itself originate during embryonic development. In addition, mesonephric remnants may undergo endometrial differentiation and give rise to endometrial tissue, hence they bleed also. Or the last, which is the most latest theory that they have, is that they have a stem progenitor cells from the bone marrow that differentiate into the endometrial tissue. Regardless of what theory you think is plausible, it gives you the same. It releases inflammatory mediators. It increases estrogen production by endometriotic stromal cells, and the expression of which leads to, as I have said, the presence of glands and stroma in the sites that were enumerated. And you may have this clinical manifestation verbalized by your patient. So, what is then the difference of endometriosis with adenomyosis? Look at the, well, this is a wrong spelling. There should be an O here. The Mayo here should remind you that you are looking for endometrial glands and stroma embedded within the myometrium, which is supposedly that the endometrial glands and stroma are 2 to 3 millimeter away from the basal layer of your endometrium. Now, the bleeding may be also secondary to polyps. These are examples of polyps. It may be the endometrial polyp, may be broad-based, it may be single, it may be multiple like this, it may be single like this. So let's take, for example, that this is what we took and this is our slide right now. And so that is your pushed by a stalk, it may be broad-based, it may be sessile. Whatever it is, you will see endometrial glands that is reminiscent of that of normal. Sometimes you may see hyperplastic changes, as in this patient. There are tubular glands, there are cystically dilated glands, and there are glands that are somewhat exhibiting crowding. So that's example of hyperplasia. So polyps may be hyperplastic. They are characteristically supported by a fibrovascular stroma. The presence of thick-walled blood vessels are characteristic of polyps. They may even follow the menstrual cycle, meaning they may have secretory activity. When they do that, then that is what you call spinal polyps. I am in the part of the chapter talking about hyperplasia. Hyperplasia from the cell should be increased number of glands relative to the stroma. The problem with endometrial hyperplasia, look at the second bullet, is prolonged estrogen stimulation, and often it is also due to inactivation of P10 tumor suppressor genes. Hyperplasia is divided into four: simple, complex, and I want to use this to explain it. So when you are having a hyperplastic process, the endometrium is expected to be thickened than normal. So if you're going to analyze this specimen, this is the area of hyperplasia. Hyperplasia in the old classification is divided into four types: simple, without, simple with, complex without, complex with. Now, the term simple and complex actually refers to the architecture of the glands. If you see tubular, cystically dilated glands, that is simple. If you see little intervening or no intervening stroma, then that is complex. Next is, these phrases refer to the atypia. So the atypia, when observed, is very much clinically significant. Now, let us try to other slides. There are a lot anyway. So in here, this is an example of tubular cystically dilated gland. So the architecture is simple and there is no atypia present. In here, there is more branching of the gland. So this is an example of complex without atypia. However, this is now lined with little or no intervening stroma. And when you look at it under the microscope, there is basically atypia. The single layer lining is no longer appreciated. So that's the fourth-year classification. However, if you're going to read your book, there are, if I recall it correctly, I think there's a paragraph there actually describes the recent WHO classification in 2 sentences only. And that is, one, they no longer classify it whether it is simple or complex. It's no longer necessary. They now classify it as with or without atypia. The term is actually, for example, here, we can call this non-atypical hyperplasia. And this one is an example of atypical endometrial hyperplasia. It is otherwise known as endometrial intraepithelial neoplasia. Okay. So why is hyperplasia important? Because eventually it may give rise to malignancy. And when we're talking of malignancy of the endometrium, we actually have 2 types of endometrial carcinoma. the type 1 and the... Okay, let us try to analyze. Type 1 endometrial carcinoma, if we are to compare, this often arises on the background of hyperplasia, while type 2 is often on the background of atrophy. Younger patients for type 1, older patients for type 2. Obese patients for type 1, thin patients for type 2. Okay. Background of hyperplasia for type 1, background of atrophy for type 2. Common here is for type 1 is the endometrioid type of malignancy. Common for type 2 would be your serous clear cell or your mixed Mullerian tumor. Common for type 1 are these mutations, particularly P10. Common for type 2, number 1 on the list will be your TP53. Okay. Let us talk about this. This is a spectrum showing you the mutations and at the same time, the growth from proliferative to hyperplastic to complex to atypical hyperplasia and basically to endometrioid adenocarcinoma. So when you have endometrioid, this is, again, ulit endometrioid is often arising on the background of hyperplasia. So this uterus, that's the mass, okay? And these are the malignant glands. If you see gland formation predominating, that's well. If you see solid sheets at glands, that's moderate. And if you see predominantly solid sheets, that's poorly differentiated. So well-differentiated adenocarcinoma, moderate or poorly differentiated. Type 2, okay? Type 2, again, is some, if you will recall, arising in the background of atrophy. The precursor lesion is an endometrial intraepithelial carcinoma. The most common variant would be your serous. Hindi lang serous ha, may iba pa. Yan, serous, clear cell, and MMT. The most common is serous. So, going to look at this illustration. This is an example of type 2 endometrial carcinoma. So, going back again, you have endometrial intraepithelial carcinoma as the precursor lesion. So when you say intraepithelial, it is supposed to be confined to the glands. So this image tells you that this is an example of intraepithelial carcinoma. And this is an example of highlighting its expression using the immunohistochemical stain P53. So since the glands are the ones that takes up the brown color, that tells you that the lesion is intraepithelial or within the gland. Now, we're talking of serous as, nandito tayo ha, but eventually it may lead to your serous carcinoma. The image below is an example this time of a progression to serous carcinoma. Now, here, as you can see, you have papillary fronts, and often these papillary fronts likewise express P53, but this time they are now invading the stroma. So this is an example of serous carcinoma invasive type. So this is a rundown of some specimens which actually tells you how extensive it can be. This is the tumor, and look at the myometrium is. Okay. Why am I emphasizing that? When you are signing out cases of malignancy of the endometrium, it is important to note as well, again, the extent of invasion. Is it lesser than half of the myometrium or more than half of the myometrium? Does it extend into the endocervical or cervical region? So here, is now an example of your atrophy. And here, this is an example of your atypical glands. Again, invasive component. So, why do we have to run through all of that? Because again, just like in the cervix, you have to know the stage, and the prognosis of your patient. Now, the third on the list, kanina, is MMMT, or malignant mixed Mullerian tumor. It is called mixed because you see two things. One is epithelial component, gland, and the other one is the mesenchymal component, which may appear in the form of sarcomatous components like skeletal muscle, cartilage, adipose tissue, bone. Okay, so it's called malignant mixed Mullerian tumor because you look for two patterns. One is the epithelial, two is the stromal. In this slide, it is actually depicting spread or metastasis to a lymph node. And the one that metastasizes specifically for this patient is the epithelial component. So the risk of metastasis is again very important to note, so that you know whether you have to do additional therapy for your patient. There is also the so-called tumors of endometrial stroma. So we are now on the stroma. It may be adenosarcoma, or which are, from the term itself, the diagnosis is based on the presence of malignant appearing stroma, which coexist with benign glands. Again, benign glands, malignant stroma. We're talking of stromal tumors, okay? When in the stromal tumor category, you have benign stromal nodules and also endometrial stromal sarcoma, which is further subdivided into low-grade or high-grade. Now, let's talk about the myometrium, and I want to use pictures instead. So this is an example of a uterus that is bisected. So it's actually a flap made, one of which is on this side and this side. Put that together, you have the uterus. So let us orient first the specimen. That's the uterine cavity. This is the cervix. And these are the leiomyomas that we're talking about. There are three locations of myoma. One, it may be submucosal, meaning it is covered by the endometrium. Okay, so that's submucosal. It can be embedded in the myometrium, and that is what you call as intramural. Or it may create protrusions that actually distorts the shape of your uterus, and that is what you call as subserosal. Whatever is the type, leiomyoma is a benign tumor of smooth muscle origin, and it is perhaps regarded as the most common tumor in women. There are some rearrangements implicated, particularly chromosome 12 and 6, and the genes are what you call as HMG1C and HMG1Y. MED12 genes are also implicated. So this is an example then of a submucosal myoma, intramural myoma, intramural myoma with subserosal component, myoma, which are composed of whorled bundles of smooth muscle with no atypia. Why am I emphasizing now the word atypia? Because the lesson I'm supposed to teach the next few slides is how to differentiate it with malignant counterpart, which is leiomyosarcoma. Take note that you have to look for three things. One is atypia. Two is mitosis. The mitosis should be more than 10/10 high power field. Third is necrosis. Again, atypia, mitosis, necrosis. Let us try to discuss that. Leiomyosarcoma is usually occurring as bulky fleshy masses, as you can see. It may also be polypoid masses that projects into the uterine lumen. Now, first characteristic, atypia. So look at this slide versus, let me go back here. This is characteristically split. Look at the slides here. Basically, the cells are more larger. They have prominent nucleoli, porous chromatin pattern. you have mitotic figures. Take note of the cutoff, 10 per 10. More than 10 in 10 high power field, and you see evidence of necrosis that tells you that the tumor is leiomyosarcoma. This is a better slide. That's a polypoid mass subtle slide. So again, using mitotic figures. So we count mitotic figures. 1, 2, okay, 3, 4, 5, 6, 6, 7, 8, 9, 10, 11, 12. So like in this field, I have already 12. The cutoff per hour field. Okay, so how many slides do you take? As much as one slide per every centimeter of the mass. So if you have like your mass, you are supposed to take 20 slides and count the mitotic figures in all of those slides. Okay. So do not forget atypia, mitosis, necrosis. Now, in your book, there is a one-sentence description of called as uncertain malignant potential, otherwise known as STAMP, ST, smooth muscle tumor of uncertain malignant potential. These tumors, okay, uncertain malignant potential is labeled as such because you cannot fulfill the 3 criteria. So say, for example, you can fulfill the atypia, you have necrosis, but the mitosis, the 10 per 10 cutoff is not reached. So the tumor will then be labeled as STAMP or uncertain malignant potential. So that being said, there's actually 3. Leiomyoma on the benign, STAMP or uncertain malignant potential right in the middle, and the malignant counterpart, which is leiomyosarcoma. Let's talk about the fallopian tubes. PID is this one actually. So I'm going to move here. I want to use this one. So PID, this is what PID does. Salpingo-oophorytis with tubo-ovarian abscess. Look at the ovaries and the tubes. They have adhesions. It is basically enlarged. And when you take sections of the fallopian tubes, they may even give you abscess like this. Okay. So this, again, as I have mentioned a while ago, is commonly seen secondary to gonococcus, but it may also be appreciated for non-gonococcal causes. Okay, we are now in the ovaries. Ovaries characteristically may have non-neoplastic and functional cyst. 2 terms to remember, follicular cyst or cystic follicle. They are non-neoplastic, and the size is what differentiates one from the other. You may also have what you call as corpus luteal cyst or corpus luteum hemorrhagicum. These are examples of inclusion cyst. These are examples of paratubal cyst. This is an example of a corpus luteum hemorrhagicum. This is an example of an endometriotic cyst. Mga ulit yung endometriosis. If you will recall what I was telling you a while ago, these are ectopic sites that bleeds. One of the most common would be your ovaries. Okay? In the ovaries, they appear as cystic and they are sometimes referred to as chocolate cyst. This next image is an example of corpus luteum hemorrhagicum. These are examples of luteinized cells, and these are areas of hemorrhage. Again, cystic follicle, follicular cyst basically will give you the same lining epithelium. The only difference is the size of the cyst. Okay. Now, there is a syndrome that is described in your book, that's PCOS, polycystic ovarian syndrome. You are to look for characteristics like what? Hyperandrogenism, menstrual abnormalities, polycystic ovaries, anovulation, and fertility. This is formerly called as Stein-Leventhal syndrome. In relation to our topic, take note, subcortical area. So that's the classic location. It is in the subcortical area. You see numerous cystic follicles. Sometimes it may be accompanied by stromal hypertrichosis, which is also called as cortical stromal hyperplasia, often seen in postmenopausal women. Okay, let's talk about ovarian tumors. In the book, there is a table 22-5, which is the WHO classification of ovarian neoplasm. Ovarian tumors are categorized into three: 1, 2, and 3. You should know which ones belong to what category. Now, for the surface epithelial tumor, if you're going to open your book, these tumors always have three categories underneath, which is benign, borderline, or malignant. Again, these tumors, serous, mucinous, endometrioid, clear cell, and transitional, will always have three categories underneath, and that's benign, borderline, or malignant. Let's say, for example, let's start with serous. I want to use pictures. So this is an example of a serous tumor. Classically, it is glistening on the outside, multiloculated on the inside, and it may have excrescences like this. This one, more likely, is benign serous cystadenoma. From the term itself, it is with serous fluid, multiloculated, and when you look at it under the microscope, you see glands. Now, if you see papillary excrescences like this, or more so solid areas like this, that's bad news, because often solid areas connotes a higher grade. It may be serous borderline tumor, or it may be serous cystadenocarcinoma. So take a look at this illustration. If it is benign, it is single layer lining columnar. If it is exhibiting a more complex glandular pattern, that is your borderline. If you see glandular complex pattern with stromal invasion, then that is cystadenocarcinoma. So I hope you get the difference of the three. So borderline serous tumor will usually present with a more complex pattern of appearance of the glands. However, the diagnosis is differentiated from that of serous adenocarcinoma by the presence of stromal invasion. You will also appreciate basophilic material or a rounded basophilic material, which is what you call as samoma bodies. Okay, let's talk about mucinous. For mucinous cystadenoma, goes the same, benign, borderline, or malignant. So this is an example of benign single-layer lining columnar epithelium with mucin secretion. What is important with pseudomix is to remember that mucinous tumor classically will present with pseudomyxoma peritoneum. In this condition, what you will have is gelatinous material that seems to cover, when you open up the patient, this is the operative field, that's the liver, the pseudomyxoma. And when you take sections of that, you will see gelatinous or mucin material. These are actually peritoneal implants. It may be happening as secondary to an ovarian mass, but it may be also occurring on any mucinous tumor in the GI, like for example, the appendix. So endometrioid tumors are again, just like serous and mucinous, to have benign, borderline, and malignant. The differentiating factor will then be on the lining epithelium, whether it is reminiscent of the endometrium, clear cell, okay, in appearance, or urothelial in appearance, such as this. And this is what you call as Brenner tumor. So that's group. Now, next group, germ cell. When you say germ cell, first on the list that is important is teratoma, which is a tumor derived from 3 germ layers. Okay. So this is classically teratoma. It is multiloculated. You have tufts of hair strands and sebum-like material. And often there is what you call as the dermal prominence. Teratoma is divided into 3. Mature, cystic from the term itself. You see mature elements, and often this is covered by squamous epithelium as the lining epithelium, and any structure that is emanating from the 3 germ layers is possible to be seen. Now, second type is monodermal, pure thyroid tissue or carcinoid cells is what you see. So, an example of monodermal teratoma. And third one is what you call as immature teratoma. Why? Because this time you see embryonal or fetal tissues as elements. So again, these are examples of teratoma, classically with yellow material admixed with hair on fresh state. This is a specimen that is quite having a lot of lesions. If you're going to analyze, that's an example of an more likely an endometrial polyp, small one, a submucosal leiomyoma with intramural component, a subserosal leiomyoma, an ovarian fibroma, more likely, and a cystic teratoma. So these women do have a lot of neoplasm or neoplastic growth. Anyway, let's talk about teratoma. If it's mature, often it's lined by squamous epithelium. We have skin adnexal structures and cartilage. We even have thyroid tissues, you even have fibroadipose tissues and glands. Now, if you see evidence like the cartilage here is mature, the cartilage here is immature, and seemingly with a tibia, more so if you see neuroepithelium. This is an example of immature teratoma. When you're talking of immature teratoma, they often grow rapidly. They frequently penetrate the capsule. They spread locally or distantly. And usually, neuroepithelium is what you will appreciate. Okay. Now, this germinoma is the counterpart of testicular seminoma. They look the same. You see HCG secretion, and you also see that the cells are characteristically pale looking, just like your seminoma. Take note that all these germinomas are malignant. The degree of histologic atypia is variable. They are characteristically giving you, as I have said, this empty-looking cytoplasm, which is characteristic or similar to that of seminoma. So this is a higher magnification. The next on the list is EST or yolk sac tumor. It is the second most common malignant tumor of germ cell origin. Do not forget the classic histologic feature which we call as Schiller-Duval, higher magnification of a Schiller body. Again, the term is Schiller-Duval, characteristic of yolk sac. Choriocarcinomas, on the other hand, are malignant germ cells, which most commonly is of placenta origin. Is an example, again, of a germ cell neoplasm. Often, choriocarcinoma most ovarian choriocarcinoma exists in combination with other germ cell tumor. Now, the other germ cell tumor would be your polyembryona and mixed germ cell. Now, let's go to the next category, which is your sex cord. First on the list is granulosa cell tumor. Schiller-Duval, ang isa, granulosa cell tumor are cells are resembling or are composed cells resembles granules, and they are actually of two types. One is adult and the other one is juvenile, basically because of the age of the patient. The granulosa cell tumors are usually unilateral, and they have this, again, as I have mentioned, this is what you call as Skull-Exner bodies. They are small, distinctive gland-like structure which are filled with acidophilic material. These Skull-Exner bodies stain positively. Strong immunohistochemicals reaction is expected for inhibin. So that if you're thinking of a granulosa cell, you have to see Skull-Exner. The next stain that you should look for or that you should request as a marker would be inhibin. Inhibin has this is a biomarker that is useful, again, as I have mentioned, for identifying granulosa tumor and also for monitoring the prognosis of your patient undergoing therapy. So again, Skull-Exner. Again, still on the Sertoli stromal group would be your fibroma, tecoma, and fibrotecoma. White or yellowish white is often tecoma fibroma. They're very easy to recognize. They are composed of fibroma from the root word fibroblast. Tecoma, on the other hand, are lipid droplets. So fibrotecoma are usually, again, you may see lipid-laden cells or fibroblasts. The next on the list is your Sertoli-Leydig tumors. Sertoli-Leydig tumors are usually producing masculinization or defeminization. Characteristically, and the tumor is often related to a mutation in what you call as DICER1 gene. DICER1 gene. Kung ang fibroma tecoma is yellowish, Sertoli tumor is classically golden yellow in appearance. Okay? It is usually well differentiated, in which, as it is shown in the image right now, you see tubule formation. Then you have also your intermediate and poorly differentiated categories. Now, metastasis is often coming from other organs like the GIT, the breast, or the stomach, as in your Krukenberg. The most common metastatic tumor of the ovary are usually derived from tumors of Mullerian origin. Like, for example, again, uterus, fallopian tube, contralateral ovary, or pelvic peritoneum. Okay, let us go now to the last portion, which is gestational and placental disorders. You must review the uteroplacental circulation. It is like a one-page review in the book. I want to go discussing this one. So when you receive the placenta, we have to measure the placenta. Take note of the color. This is the normal, and later you will see some evidence of infection in the other slides that are upcoming. So this is what we call as the fetal side. We have to measure the umbilical cord. We have to measure how far is the umbilical cord from the placental disc. We have to see abnormal coloration, observe if there is abnormal coloration. Then we flip it over, strip the membrane, and look at the maternal side. We need to see if the cotyledons are complete because, again, if not, then there could be retained placental fragments in the uterus of the mom, which may eventually lead to bleeding. So this is an example of a complete cotyledon. And when you take sections of that, you are expecting to see chorionic villi and trophoblast. So to diagnose pregnancy, you have to see chorionic villi and trophoblast. The endometrium of pregnancy is what we call as deciduum. So as you can see, this is secretory like activity, decidualization of the stroma, together with chorionic villi and trophoblast, enables a pathologist to diagnose that the specimen is basically products of conception. Now, we can also tell whether the pregnancy is immature or premature or term pregnancy. This is an example of more likely a premature or immature pregnancy. Why? Because there is no blood vessel and the sizes of the villi are somewhat larger. As the vessels are as it matures, it tends to be almost of the same sizes. That's one. It tends to be vascularized. So it tends to be smaller, more vascularized. That tells you that the placenta is mature or third trimester. Now, we have to observe the umbilical cord. Classically, it has to have 3 vessels, 2 arteries, 1 vein. Again, 2 arteries and 1 vein. Characteristically, arteries are thick-walled, veins will have a bigger lumen. 2 arteries, 1 vein. So something is wrong with this umbilical cord. We only see 2 holes. Okay? So that can be a bivessel umbilical cord, which is an abnormality. So this is how it should look like. 2 arteries, 1 vein. You know that it's an artery because it is thick-walled. Okay? Veins, the walls are thinner. The lumen of the veins are much larger as compared to arteries. Now, let's talk about gestational and placental diseases. It may be that you'll have a miscarriage. So this is what happens. So a DNC is done and we have to look for villi, trophoblast to diagnose that it is basically abortion or products of conception. It may be ectopic pregnancy as the problem. From the word itself, it means that implantation is outside of where it should be, which is the endometrial cavity. Among those enumerated here, the more common is actually arising in the fallopian tube. So the implantation is in the fallopian tube and the baby cannot grow there. The size cannot be accommodated. So eventually it ruptures. And before it goes into that part, you must do an operation because eventually if this happens, it will then end up more likely in hypovolemic shock, leading to the mortality of the mother. So before that is reached, you have to do salpingectomy or termination of the pregnancy. So this is an example of a salpingectomy. You cut through the tubes, and this opened area here is basically the point of rupture, same as here. So you cut through the tubes, and as you can see, there are blood clots on the serosal surface, which tells you that that is the point of rupture. This is the baby. That is an example of an abortus. So when we take sections of which, we have to splice this like that, so that when you take sections, you can see the lumen side, and you can also see the chorionic villi and the trophoblast and the muscle in between. So then we can diagnose that this is an extrauterine or a tubal pregnancy. Now, for twin placenta, when we examine the twin placenta, this illustration is very useful. We have to identify what is the type. Is it dichorionic, diamnionic, dichorionic, diamnionic, monochorionic, diamnionic, or mono-mono? So chorion and amnion have to be identified. Next, we have to measure the cord. Okay, we have to measure again the cord. You have to see if there are 3 vessels, and you have to see how far it is from the nearest margin. We also take samples of the chorioamniotic membrane. So this is an example of normal. And then, as I have said, you have to measure everything. Why? Because in presence of infection, Often it is very much appreciated in sections taken from the placenta and that of the membranes and even in the umbilical cord. Now, there are abnormalities in the placenta. I want to use images, so I'm going to flip again to the next slide. So this is an example of normal implantation. This is an example of placenta accreta, increta, and percreta. Normally, there is a decidual layer that separates the myometrium from the growing placenta. That decidua prevents the placenta from going inward. If you do not have one, there are three things that might happen. Is it involving this much? Okay, so accreta is only superficial layer of the myometrium because you do not have the decidua, or is it involving the inner layer of the myometrium, which is increta, or is it in a manner that it can actually extend up to the serosa and cause uterine rupture? This is what you call as percreta. So how do you treat this? Well, you do CS or cesarean section and may even end up with hysterectomy, delivery of the baby with hysterectomy. So again, we are now in the phase of placental infection. A while ago, I was showing you the normal placenta, and look at this, the color is somewhat yellow. So that tells you that there is possibility of infection. So when you take sections of the chorioamniotic membrane, you actually see a lot of inflammatory infiltrates. You can do culture, but somewhat the presence of inflammatory infiltrates already tells you that there is chorioamnionitis and placentitis, which then tells you that more likely the infection is present, and one of the more commonly implicated would be your listeria. Preeclampsia and eclampsia was described in the book, and well, the similarity is that they will usually present with proteinuria, hypertension, and edema. When you have eclampsia, usually your patient will have neurologic manifestation like seizures. Now, let's go to H-mole. H-mole is abnormal gestational disease. It is often caused by either of which, complete mole, partial mole. These are the two types. And this is why are you having a complete mole. Single sperm, two sperms, division, and eventually all of these karyotypes. So one way to diagnose molar pregnancy is to do karyotyping, in which you can have all of this. That will then differentiate whether the mole is partial or complete. But you must understand that this is abnormal pregnancy. So the patient will present with the normal signs and symptoms of pregnancy. An HCG, when tested, is expected to be positive. If a titer is obtained, the HCG titer is also expected to be high. On the other hand, when you do a sonogram, instead of seeing a baby, you will see vesicles. So that tells you now that the pregnancy is molar. Now, molar pregnancy are of two types. It may be complete or partial. Regardless of whether it is complete or partial, you look for two things. One is trophoblastic proliferation. Two is enlargement of the chorionic villi. Let the name guide you. If you see uniformly enlarged chorionic villi uniformly, that tells you that more likely what you're looking at is a complete mole. If you see that the villi are sometimes enlarged and sometimes small, then that tells you that more likely you are looking at a partial mole. Take note, though, that for both cases, you will have to have trophoblastic proliferation. So this is an example of vesicles that literally filled up the uterus and ended up with hysterectomy. So this is an example of a complete mole, and this is an example of markers like P57. Expression of P57 can be useful for normal chorionic villi and complete mole, because here it is expected to be positive, here it is expected to be negative. Now, with molar pregnancy, there is a chance for it to perforate the uterine wall. And when it does, when it is capable of going through the wall, this is what you call as invasive or invasive molar pregnancy. Now, this is an example of invasive mole. Again, the risk of perforation is there. Choriocarcinoma is often presenting, I'm going to use this, as a hemorrhagic mass. It invades the uterine wall. It is actually a malignant tumor, as you can see here, full thickness invasion. Choriocarcinoma will not give you villi, it will give you trophoblast. The manifestation would be irregular vaginal spotting, browny discharge. Bad thing about chorio, well, the widespread metastasis is characteristic. The most common site of metastasis could be the lungs in 50% of the cases, and the vagina, followed by the brain, liver, bone, and the kidney. Often it goes to the lungs. HCG of trophoblastic cells, and they're expected to secrete HCG. Now, let us try to go to the last, which is PSTT. PSTT is a neoplastic proliferation of the intermediate trophoblast. They are usually polygonal in shape, and they are usually characterized by mononuclear cells with abundant cytoplasm. It is also malignant trophoblastic proliferation. They are diffusely infiltrating the endomyometrium. They usually present as uterine mass. It is usually accompanied by abnormal uterine bleeding or amenorrhea. And again, HCG levels are expected to be elevated. It may follow a normal pregnancy or basically spontaneous abortion or even identiform mode. So these are examples of, again, abnormal placental site trophoblastic tumor. Okay, that ends the lecture. Thank you very much for your kind attention.